is Chapter 24, Care of Patients with Peripheral Nerve and Degenerative Neurologic Disorders. I also have posted a video with these diseases on Blackboard that goes into a lot of details to further help you understand these disease processes as well. So take a look at that video as well to further help you. So Parkinson's disease, it's a slowly progressive and degenerative disorder. It's actually one of the most common neurologic disorders in the United States. It can appear at any age. However, it's rare in people younger than the age of 30. And so the risk for Parkinson's increases as a person gets older. The cause of Parkinson's is it's not known. It's typically unknown for the cause, but some cases can result from exposure to like toxins like carbon monoxide or something like that. It could be drug induced. It can be a history of head trauma. Can also increase individuals' risk for Parkinson's disease. So it affects the extrapyramidal system, which influences the initiation and completion of movement. So as you'll see some of the signs and symptoms with it, the movement is affected with Parkinson's disease. So there are several signs and symptoms you'll notice with Parkinson's disease. The onset is usually gradual and starts with just maybe one side of the body. You'll see tremors with this patient, and the tremors may increase with stress or anxiety, but the tremors noticeably decrease when the person has purposeful movement. So they raise their hand to do something or whatnot, the tremors will decrease noticeably. They might have unilateral pin rolling tremors. Bradykinesia. Bradykinesia means slow movement, so their movements are slow when we're talking about bradykinesia. High-pitched monotone voice. Difficulty walking. You might hear this person has a shuffling gait. So shuffling gait is something that's that you may notice with individuals with Parkinson's disease. Muscle rigidity that resists passive muscle stretching. It may be uniform, or it may be, like a jerky type rigidity. They might have drooling or dysphagia. So with this when we talk about the shuffling gait or difficulty walking, so some of the things we need to look for, of course, this person might be at risk for falls if they have this shuffling gait. We got to look for, if we're talking about drooling or dysphagia, dysphagia meaning difficulty swallowing, then they might be at risk for aspiration or difficulty swallowing. If they're having difficulty swallowing, then maybe their nutrition decreases because they're not able to eat like they need to. So you need to think of all of these type things that could be happening for this person. They might walk, bent forward when they're walking. So again, putting them, at risk for falls and things like that. So when we're talking about treatment of Parkinson's, of course, we want to, provide things that's going to help relieve the symptoms and give them their most optimal level of functioning, depending on what's going on. The typical drug therapy for Parkinson's, you'll notice, is the levodopa, which is a dopamine replacement. So it's most effective in the earlier stages. On page 556 in your book, box 24-1 gives you some implications to look at for your Parkinson's drugs that are used. And so, like we said, the movement is going to start to get slower. Their gait is going to become difficult with that shuffling gait. They're going to walk bent over. So physical therapy to help try to maintain as much level of functioning for this patient as possible, trying to preserve their ability to do things. Emotional support, you can just imagine how this is going to play on a person's mind. They're starting to become dependent on other people. So you think about how that can affect a person's mental status. So you're going to want to provide emotional support for this patient. So some of the drugs for these patients, they might be on a variety of anti-Parkinson drugs to help decrease the presence of tremors and rigidity and the bradykinesia. So like I told you, the common one is the levodopa. So they might be, on the carbidopa, levodopa, or just levodopa. The carbidopa, levodopa, you might also see as Cinemet. They might also be on antivirals to decrease the bradykinesia and the rigidity. They might be on anticholinergics to help decrease their tremors as well. MAO inhibitors. MAO inhibitors also help, decrease tremors and rigidity. So we're trying to treat these symptoms depending on how severe these the cases or how advanced it may be. Some people have to be, every couple of hours, receiving these anti-Parkinson's medications to help, with the tremors and things like that. A couple of precautions you want to take with individuals taking the MAO inhibitors. You want to caution with foods containing tyramine, so like your aged cheeses or anything that's fermented, smoked fish and meat, yeast extract, because these things combined with the MAO inhibitors can dangerously raise your blood pressure. Also, taking meperidine with the MAO inhibitors can excessively increase your temperature and resulting in death. So you want to be careful with your patients taking those MAO inhibitors. So again, with the MAO inhibitors, just make sure have your patient talk to the pharmacist before they take any other medications or mixing any other medications with this, because you don't want any adverse reactions occurring for your patient. All right, so when you're talking about patient teaching for your patient with Parkinson's, you want to teach about different things that might help with their activities of daily living, depending on what their issues might be. Teaching them different things to help with that. High fiber diets, because things are slowing down. Everything is going to slow down. So the GI system is going to slow down. Peristalsis is going to slow down. So when things start to slow down, you have increased risk of constipation. So you want to make sure you're teaching them having high fiber fluids with adequate I'm sorry, high fiber foods with adequate amount of fluid intake to try to prevent any types of constipation. If they're drooling, or having, difficulty eating, make sure they sit up, upright when they're eating so they don't choke on their food or anything. Close their lips, keep their chin up to help with eating, and use a straw when they're drinking can be helpful. Writing may become difficult, so maybe using big strokes will help help them write better, or using a larger pen. Exercising regularly to help keep things moving so they don't, lose function or lose mobility for as long as possible. Make sure they walk slowly, use their cane, use their walker, whatever it is that they have to assist them in walking, because they will have that shuffling gait and they are at risk for falls. Teach them to, change positions slowly, take their time, not, trying to move around too fast. Multiple sclerosis is a major cause of chronic disabilities in young adults. It, it, it results from, the cause is unknown, but it results from a progressive demyelination of the white matter of the brain and the spinal cord. And it's characterized by exacerbation and remission, so periods of exacerbation and remission. And so the prognosis, varies from patient to patient. It can progress rapidly, causing, patients to be disabled early on, or it can cause death within a matter of months or so. So each person will be different, but people can, a good majority of people can go on to lead active, productive lives, you know, especially, when they have their periods of remission. So you have four clinical progressions for multiple sclerosis. You have your relapsing remitting progression, which is your most common. So you go back and forth between remission and exacerbation. And so when you're in the remission stage, you can have partial or complete recovery. So like I said, these people can go on and live, active, productive lives when they're in their remission period. You have primary progression. So with this one, it's a slow, just probably like a slow, continuous worsening of the disease from the time you are diagnosed. Sometimes you might plateau where it's just no decline, and then maybe even a small improvement, but for the most part, you're slowly worsening over time with that primary progression. With secondary progression, the initial period of relapsing remitting, so in this secondary progression, you're going back and forth between, initially, you're going back and forth between the relapsing remitting. So you're going back and forth between exacerbation and remission. And then after a while, you're just going to just steadily worsen. You're just going to steadily just get worse after a while. You don't go back and forth in the secondary. And the last one is the relapsing progressive. The relapsing progressive, it just gets worse from the beginning of onset. It just constantly worsening from onset. So these patients, they'll have some motor dysfunction, sensory dysfunction, and some problems with their coordination. So when we're talking about motor dysfunction, weakness or paralysis of, either, of their limbs, their trunk, their neck, diplopia, so that's like double vision, sensory dysfunctions. They'll have, numbness, tingling, burning, painful sensations. They can go totally blind. They can have blurry vision, dizziness or ringing in the ears. And as far as coordination, ataxia, so difficulty walking. And difficulty swallowing, at some point, slurred speech. So all these things. So of course, we got to, same thing, when we're talking about weakness, paralysis, difficulty walking, we got to, do our falls precautions. We got to make sure they're able to, maintain their ADLs. If we're talking dysphagia, we got to do things to try to prevent aspiration when they're eating. Eventually, if they're not able to swallow, then there may be some difficulties with nutrition. So you got to think of all those things when we're thinking about, these type issues going on with our patients. These patients may also, like we talked about with our Parkinson's patient, having depression. So, you're just thinking about, at this point now, I'm starting to have to depend on people. I can't do things for myself. I can't eat. I can't walk. So you start to get depressed, and so their mental state, can be altered in that way. Also, their mental state can be altered in that they might have some impaired judgment, or in the late stages of MS, they may have some memory loss as well. Fatigue, fatigue that's worsened by heat. So that's a key one for MS. It gets worse by heat, so we don't want them, in the heat or in the hot showers or in, things that's producing heat, because that's going to make it worse. And then in the late stages, because that weakness just continues to progress on and they can't do for themselves, so they may have urinary and bowel incontinence, altered sexual function. And so all of this, of course, is going to decrease their self-esteem as the disease progresses. So when we're talking about treatment of our MS patients, we want nursing interventions that's going to focus on maintaining their mobility, ensuring proper nutrition, controlling the pain when they're in their exacerbation stage. We want to form a care plan that's based on the patient's abilities and their symptoms. So, meet them where they are, provide physical therapy, provide massages, relaxing baths, but not, hot baths, because like I said, the symptoms can be exacerbated by heat. But you want to do things that's going to promote comfort. Assist them, with active exercises, stretching, things to help maintain their muscle tone and their joint mobility, and reduce spasticity. You want to improve, those things will help, also maybe improve their coordination or things like that. Things that can help boost their morale, encourage emotional stability, help them to develop a daily routine that can help to maintain their optimal level of functioning. And they'll have, some type of drug therapy as well. So you want to also watch for any adverse effects of any drugs that they may be on. So Alzheimer's disease, we're going to talk more about it when we get to the mental health diseases later in the semester. But Alzheimer's disease is a progressive neurologic disorder that affects the brain and results in cognitive impairments such as impaired thinking or memory loss or bizarre behavior. It's the most common form of dementia, and does lead to death in adults. The cause is not known, but several factors can contribute to the disease, such as head traumas or things like that. It is a slow onset, and which is a little different, as we'll talk about later in the semester when we're differentiating between dementia and delirium. But it is a slow onset, and it progresses, at different rates for different patients. And like I said, eventually it is fatal. Amyotrophic lateral sclerosis, ALS, which is also called Lou Gehrig's disease. It causes a progressive, the cause of it is not known, but it causes a progressive physical degeneration of the body. And so what is happening, electrical and chemical brain messages are not reaching the muscles to activate them, to let them know to move. And so patients with this disease typically die within about 3 to 10 years of developing the disease. One key factor with this disease, so they're having a physical degeneration, and so eventually everything is going to stop functioning, except their mental status will remain intact. So that's a different than some of the other diseases that we talked about. So this individual, the mental status will remain intact for a patient with ALS. So you can just think what that does to the person as the disease is progressing. So with this patient, they're going to have, weakness of all their voluntary muscles. They're going to slowly, start to lose their ability to do things. So they'll have impaired speech. They'll have difficulty chewing and swallowing. So with that difficulty chewing and swallowing comes, the risk of choking and things like that. Excessive drooling. They're going to have difficulty breathing, so we're going to have to monitor their respiratory status at some point. Do they need to get on a ventilator at some point? Possibly. Depression, like I said, just think what this does to a person's mind. Remember, their mental status stays intact, but they're losing all functioning of their body, are not able to do anything. So depression, does become an issue with this person. So we want to implement a rehabilitation program that helps to maintain as much independence for the patient for as long as possible. Help the patient to obtain any equipment that that will help their ability to move around, like a walker, a wheelchair, or whatnot. Depending on their muscular ability, help them to bathe and do their hygiene, transfers or whatnot, helping them, with skin care. You want to prevent any breakdowns because, eventually they're not going to be able to move and do things for themselves. So they're going to be at risk for skin breakdown. If they're having trouble swallowing, you want to, get that speech eval or whatnot to see, do we need to, get thickened liquids or what kind of things can we do. Make sure they're sitting upright when they're eating their meals, giving them soft foods. Maybe they get to the point where they need a G-tube or something like that to help them eat. Support, for the patient and the family as well. Monitoring their pain level, monitoring their respiratory status. Like I said, they're going to not be able to, breathe on their own at some point. Doing thorough neural checks on this patient. So again, you need to know your know how to do a neurologic assessment. So Guillain-Barré syndrome. Now, this is an acute, rapidly progressive disease that causes muscle weakness and some mild distal sensory loss. The exact cause of this is unknown, but typically it follows like a viral respiratory infection or some type of gastroenteritis in adults in about 10 to 21 days after the infection occurs. Now, like I said, it does have these rapidly progressive muscle weakness, but about 95% of patients with Guillain-Barré will experience spontaneous and complete recovery. But some people do have maybe some mild motor or reflex deficits in their feet and legs after the disease has passed. So symmetrical muscle weakness usually appears in the leg first, and then extends to the arm and facial nerve within about 24 to 72 hours. You also might have some dysphagia, some muscle pain, some mild sensation, numbness and tingling in the hands and feet. There'll be a progressive weakness, some facial diplegia, which is facial paralysis. So bilateral facial paralysis, dysphagia, and these symptoms, might peak within about 14 days. You might have these symptoms to peak. But like I said, about a good 95% of patients will spontaneously recover from the disease. So you want to watch for the ascending motor loss. You want to monitor the patient's vital signs and their level of consciousness. You want to monitor their respiratory function, make sure they're breathing okay. Monitor for any signs of confusion or anything like that might indicate decreased oxygenation. So, and you want to monitor their oxygen saturation as well as their arterial blood gases. Provide good skin care again, because if they get to the point where they're not able to move appropriately, then they will be at risk for skin breakdown. So we want to prevent skin breakdown. We want to perform passive range of motion exercises, pending if they're having any pain. So monitor for any pain or whatnot. Assess the patient's gag reflex. Are they having difficulty swallowing? So monitor for that, and provide appropriate care as far as that goes as well. So again, respiratory status, overall, do they need making sure they have adequate ventilation, so monitoring their oxygen saturation levels, monitoring their arterial blood gases, make sure we're assessing their breathing, make sure we're assessing their pain. Are they at risk for aspiration if they're having difficulty swallowing? So are we taking precautions to prevent that, providing soft foods, having the patient sit upright when we're feeding them. Maintain communication, with our patient. Nutritional status, if they're having difficulty swallowing, then what are we doing for their nutritional status as well, and helping them to maintain a normal function. So doing those exercises, making sure they have therapy, trying to, maintain their optimal level of functioning. Okay, so polio, post-polio syndrome, poliomyelitis, it destroys the motor cells in the spinal cord, the brain stem, um, in the motor strip that's in the frontal lobe of the brain as well. So this is, they do have a not a virus, I'm sorry, an immunization that can be given to help prevent this. But it causes weakness, pain, fatigue. It can be temporary or it can be permanent for these patients. It just depends. But swimming in warm water is therapeutic for these patients. So that's something, key to remember. And so basically these patients will have to change their lifestyles to, try to do things to conserve their energy more and preserve their physiologic function, to try to maintain their most optimal level of functioning, because they're going to be so, weak and in pain and have, just be fatigued. Huntington's disease is a hereditary disease that causes degeneration in the cerebral cortex and the basal ganglia, and it leads to like a chronic progressive mental deterioration that ends in dementia. And so the cause is unknown, but this is a progressive disease that will cause disability and eventually death within about 15 to 25 years of developing symptoms. So with this disease, your patients will have severe choreic movements, which is involuntary, rapidly, usually violent movements without any purpose, so purposeless movements. Initially, it's unilateral, and then more prominent in the face and arms than in the legs. Dementia, like I said previously, usually mild at first, and then it starts to get, more severe. Loss of musculoskeletal control, and the patient usually develops signs and symptoms in their 30s and 40s, but the onset of the disease may be earlier or later in life. When the onset begins before the age of 20, the condition is called juvenile Huntington's disease. And earlier onset often results in a somewhat different presentation of symptoms and faster disease progression. So you want to attend to the patient's basic needs, such as their hygiene, their skin care, their bowel and bladder care, and their nutrition. You want to increase the support as the mental and physical deterioration becomes more pronounced. You want to provide emotional support. The patient and the family might be overwhelmed. So, with this degenerative, irreversible disease, so we want to make sure we provide emotional support to both patient and family. So myasthenia gravis produces sporadic but progressive weakness and abnormal fatigue in the skeletal muscles. The weakness and the fatigue are exacerbated by exercise and repeated movement, but it can be, improved with drugs. Usually, it affects the muscles that are innervated by the cranial nerves, so like the face, the lips, the tongue, the neck, the throat, but it can affect any muscle group. It has an unpredictable course that includes periods of exacerbation and remission. There is no known cure, but drug treatment has improved the prognosis, and it allows patients to lead relatively normal lives. except when they have their periods of exacerbation. If the disease does involve the respiratory system, it can be life-threatening, as you could expect. So signs and symptoms, you might see gradual, progressive skeletal muscle weakness and fatigue, and it usually worsens during the day. Weak eye closure, ptosis, which is a drooping of the eye, diplopia, which is double vision. They might have a blank mask-like facial expression. They might have difficulty chewing and swallowing, a bobbing motion of their head, symptoms of respiratory failure if the respiratory muscles are involved. Their voice might be hoarse or nasal. Voice volume decreases toward the end of their sentence. So all these are some signs of myasthenia gravis. So we want to establish an accurate neurological respiratory baseline, help the patient move secretions as they accumulate in the so maybe teaching them to cough and deep breathe, or maybe using the incentive spirometer or something like that. You want to administer the drugs at evenly spaced intervals and on time, so that you maintain therapeutic levels for the patient. You want to plan periods of exercise and their meals and their patient care and their daily activities, so that you're providing care when they have the most energy, because they're going to be so weak and fatigued. You don't want to be trying to do these things when they don't have any energy. So you want to plan accordingly when you need to do those activities. Provide soft foods if they're having difficulty swallowing or anything like that. Evaluate the patient, evaluate their vital signs, evaluate their hydration status, evaluate their elimination status, evaluate their skins, make sure they're not having any issues with skin breakdown, and putting precautions in place to prevent skin breakdown. Encourage the patient and their family to talk about their feelings, because again, depression can set in because issues that are occurring with the disease process.